Hi. Right. Do you want to give the instructions on microphone? I know you do this in every meeting and I always forget.
We do have lots of new attendees, so the microphone's in front of you. For our colleagues on the hybrid call to hear you, you have to use your microphone. So if you just look at the microphone in front of you, you'll see that your name is just on the side that you're sitting on. When you want to speak, you just press the button, red light comes on, colleagues will hear us online. When you're done, turn off the button and the red light.
Thank you. And even if you can hear everything here, the people on the meeting won't be able to, and there are a number of people online, so that's the value of it. So thank you. Thanks for that. Every time I go, someone has to explain it. Okay. Welcome. Lovely to see you all. We got a number of apologies. I've got a number of people attending for in lieu of them. So apologies. I've got Moira Wilson, Ben Anderson, Damien Allen, Wendy Loudner, and Jamie attending. Nice to see you. Emma Latimer and Ian's attending. Good to see you. And Richard Parker's just rung in this morning. Thank you, everybody. But we can confirm that we are actually quorum. I've got no declarations of interest. Is that okay? Okay, grand. Minutes of the meeting on the 3rd of July. Are they okay for accuracy? David?
Just very minor one, page 11, just quippy. There's an extra U in there that needs to come out. So thanks.
Okay, action log. Anything on that people want to pick up? Anthony, to pick up, Kevin?
You would think, wouldn't you, that I'd got used to that by now? Yeah, just the reference number 5524 and the update on the BCSE, so that's been confirmed for November board session. So just to know that.
Thank you.
So on action 5924, I think that we can close that. I think the IPR going forward is picking up the outcomes framework that it references, and the second part of it was I'm bringing diabetes today. I think I originally said it would be renal, but as we go through the specialised commissioning, renal kind of comes. It's a case for change there. So if it's okay, close that action. I'll bring it back when it's ready to come. Thank you.
Thank you, David. Nothing else from the minutes or the action log. Thank you. Sorry. Leslie, I apologise, Leslie.
That's okay, Piers. So 5424, you and I still need to meet with Katie Davidson, so we just need to get that in the diary.
And I met with Katie and I've had a conversation, so you and I, let's pick it up when we go afterwards.
Wonderful. Thank you.
Anything else? No. Thank you. Let's move on to storytelling. Lucy, why don't I ask you to introduce everybody and introduce the subject? Lovely to see you. Welcome.
Thanks, everyone. Nice to be here. I'm Lucy Ettridge. I'm Assistant Director of Transformation Delivery, but I'm the Health and Equalities Lead for Sheffield Place. And with me today, and I'll be handing over to them in a minute, they're going to be sharing the patient story. But today it's a bit different. It's really about story communities. So Gulnaz, who's the CEO of Prevail Community Hub, and Abdul, who's the CEO of ACT, and they're both in the northeast of Sheffield. So I know you've got a paper and it was quite long, but just to set the context, and I'll very briefly go through it. So one of the 6 or might be 7 priorities of Health and Care Partnership in Sheffield is empowering communities through the North East neighbourhood model. And fundamentally, it's about investing in communities, the most deprived community in Sheffield, but actually really proud, brilliant community to take action on things that matter to themselves. And this is one of the best ways we can create health and therefore reduce health inequalities. So what we're saying, it's really our way of sort of delivering the Core 20 part of Core 20 plus 5. We launched it last year. It's early days, and we spent the first year developing relationships. This is all based on trust, but fundamentally investing in 7 voluntary community sectors, but 4 organisations and 4 community leaders are leading that work to embed community development approaches in the community. And they'll talk about that a bit today. But it's really exciting. It is different for the NHS. So fundamentally, it's about each of the 4 areas where we're working in the North East will have their own community plans. And they might want to invest in sports infrastructure. They might want to invest in mental health. They might want to invest in social enterprises and pathways into employment. So it's really exciting. So I will hand over to Gulnaz and Abdul to tell you a bit more about it.
Hiya. I thought I'll just take on a bit of the leadership, and then Abdul and I have decided that he'll also join in as and when. Okay, so first of all, thank you to the ICB. Thank you to everybody who has supported us from I'd say I'll take you back to COVID. I think that's where our passion grew around developing those partnerships and relationships, the fundamental point around saving lives, saving communities and saving lives. And the passion also was driven by the disproportionate impact on Black and ethnic minority communities. And the interest that the NHS showed at that point, it developed into a very, very positive relationship, a vibrant partnership. And from then we went from strength to strength in partnership. We're working with Lucy Ettridge, and then Emma was appointed, and therefore our relationship with Emma Latimer has developed into a positive and fruitful relationship that's benefited not only our organisation but the communities that we serve. So we'll tell you a little bit about our journey. And our journey, you know, as you may not know about the Race Equality Commission report and the findings of that, and mirrored with the impact of COVID, our journey was that the leaders in those communities said we need to do more. We need to do more of the people that live in our communities. We need to do more about poverty. We're already doing, but where can we go and strengthen the work that we do? And in that, NHS played that critical role. They stepped up, the ICB stepped up and kind of came back to us and negotiated a Fairvale plan. And because me and Abdul's organisation, which is Aspiring Communities Together and Fairvale Community Hub, we were asked to look at a Fairvale plan and look at what those specific needs were and how were we going to kind of narrow those needs down and be more specific about those detriments and how we can improve the quality of life of those people that live in those communities. And myself and Abdul came up with two suggestions. That was diabetes and cancer. Okay, and we've worked quite hard over the last year before and came up with different projects they want to run. We're linked up with the Western Park, with the cancer bus. We're linked up with the diabetes, the type 2. We're linked up with the ICB board on that work, and we're making really good progress in that, and the impact of that is well measured in terms of the amount of people that come through our doors every day. We see over hundreds of people of all communities right across Sheffield, but particularly in Fairvale, Burn Grief Ward, and we are making that impact, and we are getting feedback, and we are analysing that information as we're going along. And people talk about that we've made that breakthrough for their lives. They've said that we can't navigate the system due to our language. We don't know where to go to get help. We can see that you are linked with the GPs, the boundary networks, all the people that you know that can help us. So we were able to make that breakthrough in a way that the top down can't do. It's more about the grassroots. So we're a charity, we're a company limited by guarantees, we're accountable to the membership that are made up from our local communities. Further to the work with Emma Latimer, sorry, I'm rushing and talking fast, but do come back to us with questions. But yeah, so so further to our work with Emma and Lucy, and the work that we did as a pilot for the Fairvale plan, we came up with the way that we could bring everybody in the North East together. It was very important that we brought these partners together because people said, why North East and why not elsewhere? So we had to come across challenge because we're in red. We're in red, and we are faced with our communities dying younger. And we as organisations on the front line see that every day in the work that we do. And we wanted to join in with the NHS, the ICB, to make things better for our communities. So with that, the plan came about, and VCF leaders such as Aspiring Communities Together, myself, Reach Up Youth, and SOAR Community, who are a well-established big organisation who have infrastructure behind them, came together. We brought those skills together into one room. With that, we developed a community engagement plan, and we worked at that, and we've more or less involved the community, brought the communities with us, so they're involved in every aspect of that. So we designed a survey, we asked questions that our communities can answer. Again, we were doing the bottom-up approach. Those questions were defined and co-produced by the partners themselves, the kind of questions that the community can answer, and that will form a longer term plan. So we're at that point where New Local have been involved. They've supported us to develop these community plans. These community plans have reached out to hundreds of people in our communities. People are saying what they like about their neighbourhood, what affects their life, what they like to see, what will help them in terms of health, what will make them happy, because we think it starts from happiness. If people are happy in the environment that they live in the community that is around them, that improves health in so many ways. So we're trying to capture all aspects of people's life, and with that information we aim to develop a community plan right across the North East. And I think that's our journey at this point. So is there anything you want to say, Abdul?
I think you've said enough, Gunnars. You've said it very articulate way. Just to say that I've been involved 35 years in community development, particularly in supporting people with health issues, advice work, counselling, guidance, mental health support. And for the first time in those 35 years, I can say that we're starting to work with the NHS as partners. And that's something that's never happened before in my own experience. So I think that's a very positive thing, because if things happen on the grassroots, they'll have an effect, they'll have an impact on that. And I want to thank Emma and Lucy particularly for making that decision to come out and work with us. We do a lot of preventative work. For example, our organisation, we have a healthy living centre with a gym, we have a social cafe, we have a full pharmacy, we have mental health support, and we have a community language school, which doesn't just teach community languages in terms of Arabic GCSE, but also helps those kids catch up with their maths and their English in mainstream school, and also deals with a lot of mental health issues. That school was always seen as something outside the sphere. Neither mainstream schools nor the education nor the government ever sees it, but there's 250 kids in that school, and the kind of work that we do with them in terms of knife crime, in terms of gangs, actually prevents a lot of those young people from going to hospitals. And I think that it's that type of work that we do that is fundamental to the work that you do. And I think for the first time we've got a partnership, and I hope that partnership grows. And it's not about the money. I was just saying to Lucy, I wish we could have this kind of thing in that centre, and it costs about 12, 13 grand with money which we haven't got. But if we could have that, we could have those young people using it instead of us here. So I think this partnership can work. I think the community plans will be very positive, and I think it's a new way of working. And if it works, it can have an impact in the whole of South Yorkshire.
And just adding to, it was very important in everything we do that we take the community along with us. So the community is on this journey. We're here to represent their voice. We're here to bring what their needs are onto this table at the highest level, and make sure that whatever we do, we're involving them in the journey, because the real change can only come from deep-rooted communities and from those communities themselves. And that's where we come, because we've come from those communities. We've lived and worked there, where some of us are born there. And that was very, very important to us, to make sure that they feel that they're part of this journey. And they are, with the community plans and the ideas at New Local. And Lucy and Emma have worked very closely with us have come up to make the communities that are living in those communities reassured a little bit more than feeling disenfranchised and disengaged, and living in the spins of poverty and living in those communities in the same way. So they feel listened to through community plans, and when you engage, people feel listened to. They start taking local action. They start feeling that they're part of a energy and a process that they've never been involved with before. So, with our passion, with the ICB board and the NHS, I think we're making a significant difference, and the local authority are asking to get involved, and others asking to get involved as well. So thank you very much for giving us your time and listening.
Good, Abdul, that was really, really good. Any points or questions people have got? Can I just add a couple of things? Firstly, I think this is really, really good work. We talk sometimes till the cows come home about health inequalities and how do we make a difference, and the answer is we're going to have to get into the communities in a very different way. By the way, this is not the only way to do it, but it's a really good example of us trying to do that differently. The second thing is this work has really been noticed. I was in a discussion with Tom, the council leader, who spoke passionately about how good this work was. And we were in a conversation with the MPs a month ago, who also said the work you're doing here is really, really good. The community is really engaged. There is something here that's potentially very powerful. The other thing I loved was your passion. It was really, really good. So thank you very much. Lee.
Thank you. That was great, and it's quite cheered me up. Now, that wasn't the purpose of your attendance, but it has quite cheered me up. I'm often criticised. I could almost finish the sentence there, but I'm particularly criticised about when we're trying to invest in these sort of schemes. There's a kind of whole host of money we spend as the NHS that perhaps isn't appraised as well as we're trying to appraise this marginal investment. So I'm just really interested in measurement. It might be a question for Lucy, really, just about in terms of justifying public funding being spent on this sort of scheme, which I think is essential, vibrant, and thank you for coming to tell us about it. Just getting into that measurement about that community building and what that does in terms of not needing to go to the GP as much, potentially not pitching up into secondary care as much. I just wondered how deep into the measurement we were.
Good question. Thanks, Lee. And it's touched upon a bit in the paper. We're working with New Local, and they're our delivery partner, and they're helping, with engagement, community planning. But originally, we contacted them because they're experts in evaluating community power schemes, public sector reform schemes. So we're currently developing our evaluation framework, and it won't be complete until we've got the community plans because we won't know what we're measuring. But it is going to be a balance of self-reported measures, and we're looking at in the survey that's out at the minute. We've got ONS measures, actually, what's your mental health like, what's your well-being like, and we'll track that over 5 years. But we're going to look at system measures as well, and there is actually a lot of evidence already around, it reduces social isolation, it reduces rates of dementia and CBD, and obviously, reducing dementia is going to take 10-20 years, but we need to think about what can we measure within a year, 2 years, 5 years, for the very audience of our directors of finance and national policy, and part of this is influencing national policy as well. But it definitely, it's got to be power storytelling, and we're currently creating videos and the impact on individuals that this has transformed my life, as well as how's it impacted on STH, how's it impacted on the GP surgery.
Thank you, Chair. And thank you, Gulnaz and Abdul, for coming and sharing that. I was just it's more of a comment than a question. And it's just the importance of community groups like yours to serve those communities, because you already have that trust and those relationships. So while we are trying to do things, if we wrap around your services, we can get the stuff done that we need to do. And I think it started in COVID, but it has continued, and I think it really works. And just thinking about one of the other items on the agenda, the diabetes program, when you're thinking about that, working with teams like you and other teams for learning disabilities and things like that, we can achieve our goals by working with other organizations to reach those people and tackle prevention, because we always kind of draw a fine line between managing things and preventing. So to move over to sort of community services and focus on prevention is excellent, I think. So thank you.
Thanks to both of you for coming and talking today. I really could love to know more, because I'm quite passionate about stuff like that myself, so it'd be really good to kind of know more about this as things go forward. I just wondered what made you hone down on the two things, diabetes and cancer, and where that thinking came from, because I think that's quite interesting, because it might not have been the things that people anticipated that you would have come up with as the first things to look at.
Yeah, okay. We base our service on need and demand. So we knew the questions that our communities were saying and what services they feel particularly disenfranchised with. And we also based our knowledge on the fact that we don't think in our communities there's enough around cancer awareness, that's culturally appropriate, that there's many people that we've seen pass away over a long time as well, a long period of time. And we were thinking that intervention is very weak in areas like the Northeast. And people are living with cancer, but there should have been a lot more work done around the intervention. So we felt that those two were quite key, and we are very well networked now. So just to give you an example around the way that we work and the model. So as organisations, in terms of the Race Equality Commission report, it was found that we've been quite isolated as BME leaders in the city. And now by bringing us into a platform where we can kind of offer and make sure that those communities are on board, will have that mass impact. And the kind of diabetes work that's been kind of like looked at around type 2 through the ICB, the primary care networks and the GPs are now based with us looking at those programs. It's not that everybody, if we all work, we will survive, whether ICB are board or not. It's the quality that is needed. It's not about quantity, it's the quality of work that's needed, and we can't do that alone. We need the ICB, we need the NHS, we need people like Lucy involved in terms of Health Watch, we need others, and we have got an inclusion group that's made up of GPs that steer the project. So it's about bringing everybody on board, including us, because we know the families that live there. And if you don't have that, no matter what you will do over years to come, our area will never come out of the red. Yeah, so those were the two particular ones because the communities were saying.
Thank you.
And also Cancer Western Park Museum were contacting us and building our infrastructure and allowing us to develop plans and working with other people was key. So
If I can just add quickly, but then the community plans will be very much invested in delivering what matters to communities. This piece of work around in improving diabetes and cancer is related, but it's not the community plans.
yeah,
If that makes sense, because
Yeah.
it is all about community.
yeah, that was a
Thanks,
pilot.
because that's what I was wondering.
Yeah,
Whether, you know, some of that
Yeah.
more bottom up issues that because they weren't the obvious ones that I might have imagined would have.
yeah,
I was just
yeah,
interested.
yeah. That was
in
a pilot.
why. Yeah, thank you.
I've got Will, then I've got Gavin, and then we'll move on after that. Will.
Yeah, thank you, Gulnaz Arno. It's a really powerful story. Just two things, and thank you for sharing the sort of the why cancer. It's just to remind the board, we've done over the years quite a number of surveys of our populations to try and understand awareness around cancer symptoms, and we already know that it's actually quite a low baseline in Sheffield, particularly in some of our areas, well, particularly the northeast. So I can see how that builds on that and really starts to help us attend to that. The second thing I wanted just to come back to, because we have discussed it as a board previously, is about measurements. I think there is something quite important for us to just reflect on there, because we've said that we going to have to be quite creative to think about the kinds of things that we focus on in order to demonstrate value, benefit or added. And that might require certainly the NHS to think quite differently about that. I'm just really mindful about, you know, just one of the aspects that you're focusing on, which is those trusted relationships, that the NHS would find it really hard to actually access some of those. And therefore is something about how we work really hard and get alongside and support folks like you and work like this to really start to think differently and come up with those metrics. Which I know you're doing, Lucy, anyway, in Sheffield, but I just wanted to connect it with a discussion we had at our last board earlier in the year.
Anthony.
So, sorry, Chair. I think I was just scratching my ear rather than a question. But I know you'd got only to say really impressed with the work and very eager to learn and take this into Doncaster, because I think it's got great potential for spread and sustainability, hasn't it? So
Yeah.
thank you.
Thank you.
Thanks, Chair. Ian Atkinson, Deputy Place Director in the Sheffield Place team. Hugely support the work of being around it. I think one of the challenges for the ICB and actually the NHS over the next 12 months in kind of picking all the good work that's going to come at us is, are we prepared and are we ready to have a different dialogue in terms of how we deliver service into these communities? Because these colleagues of ours that are working in partnership, we're already into a dialogue of the plans out of the community. We are going to have to adjust the ways in which we deliver our provision if we really want to lock some of this stuff down around sustainability. So it's working with the services that we've already got. We've got cracking example with the Sheffield Children's Hospital around Super Saturday when services are coming out of a traditional environment to do something different to offer high quality care. So there's something in that for us all to take in terms of actually it's doing with, and we've got an opportunity now to do something different with our service as well. So I just wanted to make that point. Thank you.
The point's really important. We're doing work in some communities. We need to pull some of our services. Still sites don't all. You can't get near them. This is not just reaching out to the community, it's just making the whole place better. I mean, I go into Sheffield Teaching Hospital at Howard, I just can't get near it.
Thank you. Ian has actually said exactly what I was going to say, so thank you, Ian. But as I've got a moment, I just want to say thank you for telling that story so powerfully, both of you, Gulnaz and Abdul. I think the way you describe it really brings to life the difference that it's making to people's lives. So thank you.
Yeah, just to echo Lucy's point, I mean, just to thank Gulnaz and Abdul for coming. It's not easy to come, you know, in a kind of formal session like this, but I have to say what you've told us this morning is fundamental, and I think of universal application across the NHS. So I can't stress how important I think this work is. And when I look at our agenda today, we've got some real challenges on the agenda. So whether that's health inequalities or pressure on services or finance, and to be frank, we've got an NHS at the moment that's designed in some ways, I think, to respond to poor health. That's kind of what we do. But interestingly, we've got to change that model because it's not sustainable and it's not affordable. So, how do we make a shift from over reliance on hospital care into, helping people to be well, to stay well, helping to keep people out of secondary care. But I thought Leslie's question was a really good one, is because I think sometimes in the NHS we assume what would be necessary to make that so. And I think the key learning from this is not to assume. It's you've got to have the conversations with people in the neighbourhoods, who are kind of contributing their own personal experience to come up with a better answer. So I think what's really powerful about what you've told us is practically how you can do this. And I think, Lucy, you mentioned about telling the story. I do think it's really important to tell the story here because, obviously this is important in the northeast of Sheffield. It's important in Sheffield, but the other places in South Yorkshire. But I do think this is important nationally. And I think telling the story and making people aware of the work that you're doing, I think is really, really critical. And obviously we'll want to help with that. But, thanks for coming.
Thank you. Great story. Really enjoyed your time. Lovely to see you. You're very welcome to stay, but how can I put it delicately? You don't have to. Thank you very much. Lovely to see you.
Yeah. Thank you very much. Thank you.
Cheers. Okay, I haven't got anything to report on the chair's matter. Gavin, can I hand over to you for the chief exec's report?
Yeah, well, I think of a better way to start the meeting than that, because it does speak to so much of what's on the agenda. I was just going to observe that clearly we've got a new government, so that's not mentioned in my report, but maybe just to share some reflections. I think the first thing to say is in the last 2 months, since the beginning of July when the election happened, I've been in two meetings with the Secretary of State, which and the reason for saying that is I think that's quite unusual when I think about kind of the history. So I do think you've got a Secretary of State that wants to be accessible and visible and kind of on the pitch, as it were. I was at a thing with Wes Streeting yesterday where he was talking about the importance of partnership and how he wants the government to be a partner of the NHS and work together, because that's the only way that some of the challenges are going to be met. But I thought it was really quite refreshing. Notwithstanding some massive challenges, I've lost track of how many times somebody has said to me over the last week or so, there is no more money, and repeated by politicians kind of yesterday. So that sense of we've got to do something different, and actually we've just heard a bit of the sort of thing that might help us. Secretary of State talked about 3 shifts. So a movement from treatment to prevention, shifting from a reliance on secondary care into making it's a terrible way of describing it, but out of hospital, but community-based care more effective, and a movement from analog to digital. So really clear in terms of the shifts that he wants to see. I have to say they speak really well to our agenda when you think about the wider partnership in South Yorkshire, the integrated care partnership with the local authorities. And I was particularly pleased to hear Wes Streeting say that he gets upset when people refer to him as the health secretary, because what he's really keen to point out is that he's also the social care secretary too. And it's been good in some of those conversations to actually be there, not just with NHS leaders, but with directors of adult social services, with directors of public health. So that sense of it's one system, I think it's good to hear that coming down from the top. It's self-evident to us. We know that, but it really helps to hear that from the Secretary of State. Just to mention, part of the entry of the new government, I think, is to develop a 10-year health plan. And again, I like the way that it's a health plan. It isn't an NHS plan. It's about those wider determinants of health and how do we work in a system to improve health. So the 10-year plan will be published in the spring. So kind of by the end of April. That's a massive undertaking. And actually, the first part of that is a diagnostic piece of work that's been led by Lord Aradarzi, who, if anybody's been in the health service for a long time, will remember that Aradarzi was very influential in the past in terms of shaping. He's a clinician by background, a surgeon, I think, but interesting to see him coming back into the fray, as it were, to help do a piece of work to take a kind of the sort of state of the nation in terms of the NHS, where's it at, and that will be one of the critical inputs into that 10-year plan. The ICB itself, I think, will have an important role in the autumn, because one of the critical parts is that there is wide stakeholder engagement in the development of this plan, and obviously we've already done a lot of work. So whether that's the health and wellbeing board strategies or the ICP strategy, there's been a lot of community engagement that's informed those plans. So I think we've also already got a lot of information that we want to contribute to that review, but we will have an active role in directly engaging stakeholders in that plan. So I think that's a really, I mean, obviously it's a critical change in the political sense, but I think really important opportunity, I think, for the NHS, and obviously we'll have a part to play in that. So I just wanted to sort of make reference to that. I'll just pull out a couple of things from my report, Chair, if I may. Obviously, since the last time we met, we had the awful scenes of racist violence across the country, and quite frankly, horrible to see that, both in our country, but also, to be frank, close to home in South Yorkshire. And I just really wanted to, just to acknowledge that although the impact on the NHS in terms of service delivery was relatively moderate, it had a big impact on our people. One of our great strengths in the NHS is the diversity of our workforce, and I think a lot of people found it upsetting and were made to feel afraid as a result of what they saw. So I think I think it's important for us to acknowledge that and I know provider organisations across South Yorkshire put a lot of time into supporting colleagues and listening, as we did within the ICB itself. I thought it was also really important to just reconfirm that one of the first things we did as an integrated care partnership was to commit to a journey of becoming an anti-racist health and care system. I use the word becoming. I don't think we could claim to be close to that today. I think we've got a lot of work to do, but I think it's an important, to make a start on that journey. But also to within the ICB itself, we've also committed, the board has committed to adopting the Northwest Race Equality Framework, which is action oriented, has external scrutiny, it's structured. So I think helping us make practical progress on that journey to become an anti-racist organisation, I think is really key. I'm pleased that other partner organisations within the NHS across South Yorkshire have also agreed to adopt that approach, and we're having conversations more widely across North Eastern Yorkshire about whether we could do something in a similar vein on a much bigger geographical footprint. But I didn't want to let the meeting go without acknowledging that. I suppose just one other point. Again, I think probably all really struck by the events in Nottinghamshire and the treatment of Valdo Calacane and the dreadful murders of Barnaby Webber, Grace O'Malakuma and Ian Coates in June 2023. The CQC have investigated that in some depth and published a report. And all systems across the country will be looking to see what learning can be derived from that appalling set of circumstances. And we are conducting our own review of intensive and assertive community mental health care across South Yorkshire to check whether we are meeting the recommendations that the CQC have made, or whether there's further work that may be needed to be done. And we will bring back, I think, to a public board meeting, possibly November. I think we'd quite like to do that. That review is taking place during this month. It'll conclude this month. So it'd be good to bring that back to a public meeting in November. I've touched already on the financial position. I mean, Lee will give a more detailed update under performance, but just to remind everybody that it is a really challenging operating environment. I think 3/4 of systems within the NHS are working to deficit plans this year. South Yorkshire's in that position as well. So we've agreed with NHS England a deficit plan of 49 million. That requires three things really: for the ICB to break even, for the NHS providers in South Yorkshire to have a deficit no greater than 49 million, and for us to use the synergy of system working to deliver a further 48 million pounds worth in efficiency savings. I suppose just one thing, again back to the story that we heard at the beginning. This isn't about we've got a financial problem, let's lurch towards finance. This is why what we've just heard is even more important, because actually if we can get some of those things right and decompress the demands on secondary care, which is the default, and as it happens, the most expensive of all solutions, then that's going to help. So, financial challenge, but working differently, improving quality, addressing some of the challenges that we talk about is actually the route to financial sustainability as well. So I think it's really important not to lose sight of that. Just one thing I do feel duty bound to say is, as a result of being off plan at month 2, we are receiving additional support from NHS England, something called the investigation and it's the that's what it is. I, thank you, Lee. But to be frank, it builds on where we're already doing. So we're already doing a kind of a deep dive into efficiency opportunities, the control environment, but also the kind of system redesign work that I've mentioned. But I think in some ways it perhaps gives us a bit more horsepower to accelerate those conversations. So I wanted to mention that. Industrial action, I guess, just to say, I mean, some progress in terms of junior doctors. There is still an outstanding dispute nationally with primary care. GPs balloted through the BMA earlier this year to take collective action. We're kind of waiting to see what happens. I think at the moment there's been relatively moderate impact here in South Yorkshire. I have to say we rely very heavily on primary care and our colleagues in GP practice particularly, and I'm kind of hoping that a resolution will be found. I know Secretary of State feels that this is sort of top priority in terms of issues that he needs to tackle. I think there's been some positive signs, a bit of relaxation around the additional roles and allowing that to apply to medical staff. So I think something like 1,000 more GPs can be appointed nationally as a result of that. So I think we've got a Secretary of State that's listening, but it's a tricky situation, and I think it's probably our biggest risk actually if some of the the potential impact of collective action were to come to pass, then I think that would make life very difficult, I think, within the NHS. So I'm hopeful that a resolution will be found. Just finally, I just wanted to perhaps end on a bit of good news whilst describing some of the challenge. So I mentioned the National Centre for Child Health Technology, which is being led by the Children's Hospital, but very much engaging the Children and Young People's Alliance across South Yorkshire and consistent with our Best Start in Life bold ambition. So it's great to see that project moving forward and the work beginning to happen. And I've also listed some awards. So Primary Care Sheffield. Well, I won't read them out because there's quite a few, but do look at that, because sometimes it's easy to be consumed by the immediate challenges without recognising some of the great stuff that's happening. So there's a list of awards there. And one of the things we did within the organisation in response to last year's staff survey, where there was a request to, could we be more active in recognising a good performance within our own organisation. So we launched our Stars Award programme back in July. I'm really delighted to say that Katie Dowson, the programme director for digital transformation, was our first Stars Award winner for some of the work she's done around particularly digital inclusion or avoiding digital exclusion, a different way of describing it. So really good to see that. And we can announce the August winner as well was Danny Bailey, who is a well-known character within the organisation, but has worked really, really hard to make some of the office moves work, which have saved us over £1 million in overhead costs, but actually quite miraculously provided better accommodation and better working environments. So you can improve quality and save money at the same time. Living evidence of that, thanks to Danny Bailey, but great to see him recognised in that way. Thanks, Piers.
Thanks, Gavin. Any questions yet?
Thanks, Chair. Can I just add a few points to Gavin's conversation around collective action? David might want to do the same. I'll start with the positive. I think we've got Well, I know we've got some very good dialogue with our local medical committees across South Yorkshire, and we are committed and we continue to have very open and transparent conversations with them, which is helping us to some extent where we possibly can try to mitigate against mitigate with collective action, which, as Gavin has alluded to, does have the potential to have a great impact on our services. The positive of that is that it's actually accelerated some of the transformation and conversations that we've needed around things like primary and secondary care interfaces. So we have a good working group of clinicians looking at our primary and secondary care interfaces, conversations, better ways of working. And actually, that's been a benefit, I think, of some of the collective action that we've been able to accelerate that work. The final thing is, and that's really a signal really of support, is that South Yorkshire is part of a national programme to have a look at new ways of working across primary care to inform a potential new contract for general practice. So there are 20 primary care networks across the country that will be undertaking this work, of which 4 are in South Yorkshire. So that's great that we're in the camp informing this work. The launch is in a couple of weeks' time, and I'm happy to come back and report on how that progress is going.
So not so good news is, unfortunately, there was an escalation yesterday. The General Practice Committee felt that the government hadn't moved quick enough or gone far enough with the collective action. So we'll have to watch that space and see what will be proposed next. Second thing is, Gavin mentioned about the Child Health and Technology Centre. We had Dame Angela McLean, who's the Government Chief Scientific Officer, visited last week, and I was part of a multi-organisation conversation with her, and she was quite impressed about how we've come together as a collective and the opportunities that might exist in South Yorkshire for us to really maximise research and innovation locally. And if I could be cheeky and just raise, it's Know Your Numbers week this week, and we've talked about prevention already in this meeting, so I'd like to just take the opportunity in the public meeting to say, you know, we're encouraging adults to find out their blood pressure, and we've done press releases, and I've given a quote that will go out, so thank you very much.
Thank you, Chair. I just wanted to give a little bit of context to the GP position. So it's a decision that didn't come lightly. GPs are not striking, we're still working, but we just wanted to make general practice safe for patients. And the way that we're working now is not safe and it's not sustainable. And I think the best way to demonstrate that is to give you an example of my typical day. I get to work at 8 a.m. I see 14 patients in the morning, 14 in the afternoon. Each of those patients has at least 3 problems, if not more. So that's 84 issues that I'm dealing with in a day that need investigations, examinations, and, you know, and everything else that you have to do, including referrals to hospital. So that's not even my full day's work, because I will get blood test reports and imaging reports. My record so far is 142 in one day that I have to make clinical decisions about. Then I have documents that come in through the hospital, of which I'd get about 20 a day. And then I have tasks where patients are asking for medication or other things that need another clinical decision, and that's another 30 or 40. So I do my day at work from 8 till 6, and then I go home and I'm on my laptop for another 3 hours. That is just not sustainable. 142 results you cannot process safely. So I think what we're trying to do is push back on some of the things that we don't need to do. So in my tests, I would have a request to refer someone for a wheelchair. That's not the job for a GP. And we get lots of things like that. So I think most of the collective action is pushing back on those things that we don't need to see and that we don't need to do. We're still seeing patients. A lot of us are still seeing more than the 25 that are recommended by the BMA. We have other patient contacts that we deal with every day. I think every GP that has entered that poll wants to make sure that general practice is safe. You know, we would urge people to still go and see their GP. The doors are still open. There are still appointments there. You will still be seen. And if the GP can't see you, they will still direct you to someone who can. We have hubs. We have a walk-in centre in Sheffield. There's iHeart Barnsley in Barnsley. So you will always be seen. There should be minimal effect to patients. And I think we are doing this mainly to keep things safe and to keep things sustainable. Practices have had to close down because they can't afford their staff. Practices have no GPs. we can't keep going the way we are. We need the resources, we need the recognition, and we just need to make sure that we're heard. And I guess that's why this decision has been made.
Okay, next agenda item is questions of the public. We have none today. So I'll move on to the police reports. They're done in alphabetical order. Barnsley, Jamie, you're going to take us through this? Nice to see you. Welcome.
Thank you. Hi everyone, I'm Jamie Wyke, I'm the Deputy Police Director in Barnsley. So I'll just pick out a few of the key areas really, and try to sort of pull a mix of things in there. There's quite a lot of detail. I think one of the key elements that I wanted to flag, we had a conversation at our police partnership in Barnsley last week around this, was around family hubs, and the opportunity that we've got to use the National Family Hub programme, the way the local authorities with partners have developed that to really get into our communities and build on some of the work that actually came out earlier. So I think we've identified that, and it were a great opportunity to share some of the areas that have been developed through our family hubs and use those locations that are in all 6 of our neighbourhoods that we're trying to build into our Elf on the High Street in the town centre as well, to sort of build that conversation. But we particularly highlighted an area which was funded through the Family Hub programme, which was around perinatal mental health, and the importance of that. So that's included in there because of some of the real successes that we've had in that area, and wanting to carry that on. And then as a result, and linked to, there's the peer support workers, were part of the SWIFT perinatal mental health service, but who bring some lived experience to work with women and men, families, to help them to sort of manage some of the challenges that come through perinatal mental health. And there's some figures in there around the numbers, significant numbers, 27% of women, 20% of men who were impacted and experienced. So we like to flag an award from Barnsley, but there's some recognition there for the SWIFT service.
Wendy has on a couple of occasions.
Yeah, she's drilled it in, Piers. Yeah, I think the other part that we wanted to sort of pull out, and this sort of resonates quite a lot because it's fairly recently that we had the Shows Up launch in the Doncaster Racecourse around the sort of cancer awareness, and we had a presentation there from the Active Together team, and we've now sort of begin to roll that out in Barnsley, so people are starting to sort of get access to that support, which we recognise is really, really important on that. A couple of other bits, and I think this picks up around, we've done our work around buildings, and Kieran, you'll recognise this, but some of the work that Barnsley Council have done and have been recognised for around the Enabling Barnsley work. So again, recognised for their innovation around digital technology, and they've been doing a big piece of work with Microsoft and 365 and the use of Copilot, which, as it sets out in the paper, there's an whole range of areas where that brings benefits and helps in terms of the efficiency, productivity, not just of sort of back office workers and in meetings, but social workers and others as well. So I think, there's real opportunities for us to learn from that and build further as well. We've included then, just building on that digital bit, some information around some work that we've been doing in Barnsley on this. So this is one of the areas of our plan. We know we need to do more to sort of embrace digital, both from a ability to access services and also how we deliver our services, but also supporting our communities to be able to utilise that. So we've had a number of workshops on that, and we're following that through with some others, with services and service users around both inclusion and how we use. And then the final thing that we're going to pick out, which is from the sort of back page, and this is not just a Barnsley thing, actually, it's because we're quite proud, but probably 10 years ago, our smoking rates were appalling, and they're still not quite where we'd want them to be. We've seen some improvements in the overall smoking rate. We've had some good results recently around smoking in pregnancy and other things, but our continued focus it's sort of shown in that chart there that, you know, second highest quit rate, and, you know, and not obviously the first highest was Doncaster, and Sheffield third actually. So three areas there, and probably also to Mark and the Swift service, because actually Yorkshire Smoke Free delivering quite a lot of the areas where we're seeing an high level of quitters, and that comes from the innovative approach and the work. And again, that's a service that works out in communities in the areas where people can access. So we wanted to flag that, because I think that's really important, and it's something that we've still got a commitment to. All our partners have got a commitment to, and I think we see that through the hospital's commitment to the QUIT programme and other things. So we wanted to highlight that as well. Thank you.
Thank you very much. Cheers. Do you have any questions? Sorry. Thank you for that. Right, Doncaster, Anthony.
Thanks, Chair. I'm Anthony. I'm our place director for Doncaster. Three parts of my report today. The first really is a preview of things to come in terms of our reshaping of health and care in the city. The second is an update on our one workforce partnership approach, and third, just an example of good practice really in the work that we're doing with care homes. To the first part then, you'll see that we have some really ambitious plans to reshape the health and care in our city, and we've made some great progress in that now, and I'm confident that I can come back to board over the next couple of board meetings and start to show genuine progress now about how we're reshaping services away from those hard to get to hospitals, Piers, and we'll be creating our city centre health and wellbeing hub with some services that are forerunners, if you like, of the potential that we can decant away from the hospital side. We're also quite excited about our redevelopment of the Tickhill Road estate, and how we can move that towards a more centre of excellence for elderly people, which is one of our key objectives through the Health and Wellbeing Board, which is improving the experience of ageing in Doncaster. So more to come on that, but some real good progress and exciting potential. Wanted to concentrate a little bit on our one workforce partnership across the place. We've got like our other places, a strategic workforce group where we bring together our key workforce and leads across Doncaster to really focus on our workforce priorities of particularly looking at employability and work and retention and recruitment. Our challenges are very much the same as in many places. Our workforce does not reflect the diversity of our communities, and there are clear barriers in terms of career pathway from education and recruitment, particularly into promotion of senior roles. And we know that from our res data, and we also have our staff telling us that they have experience of harassment and bullying, and it's higher for ethnic groups compared to other staff. And recent events that Gavin has alluded to has put that increasingly in our window. We've created a number of work streams across Doncaster. Our anti-racism partnership, which is to address inequalities and promote social justice, is really doing some great work in terms of recruitment processes, anti-racism training for staff across the partnership, and that is key priority of the Team Doncaster Executive Board. We also have our armed forces community. People will know that there's a high number of armed forces and veteran residents in Doncaster, and we're doing some great work about again enhancing recruitment practices and creating a cross-organisational staff network for promoting roles across health and care. And we've also done some great work with the Department of Work and Pensions, which I'll get to in a moment. I'm conscious of the Chief Finance Officer's challenge around measurement and justification. We do think we are starting to see some potential around increased staff morale, and we've seen that from some of the surveys across across our partnership groups, but also increased innovation within those services that comes from a more diverse workforce that we're trying to recruit and retain. An example of that is some of the work that we're doing with the Department of Work and Pensions to particularly within facilities roles. I was struck that that we have large gaps across our organisations in terms of facilities roles, and typically of 14 interviews offered, only about 2 to 4 people tend to attend the interview. So that the recruitment processes and the way that we try to get people in is obviously not working, and we're looking to with our work with the Department of Work and Pensions to make it easier for people. People will know that the applying for an NHS job through the various application routes is the same for a consultant as what it would be for somebody wanting to come and work in a facilities role. It's laboured, it's difficult, and we're doing some work that removes some of the barriers of the application form and equips our candidates for interview and for the training that they would need to do. We're starting to see a reduction in turnover, a reduction in the amount of backward that's coming for interviews, etc. And we're seeing a more diverse applications into that role. So really quite encouraging about that programme. And the final one I wanted to mention was our work with Aspire to Be, which is one of our organisations across Doncaster, to provide programmes for employability programmes for people with communications and learning disabilities. Only 37% of people who report British Sign Language as their main language are in work. And so we're doing some great work in Doncaster to make that easier for people to get into employability and to apply for roles. Some great work around that. I know that's shared in other partnerships, but I think the real benefit of this is organisations coming together to look at that. The final one is, and this plays really to the Secretary of State for Health and Care's challenge around digital. We know in Doncaster that we've got a lot of people through our audits with Yorkshire Ambulance Service attending hospitals from falls and using that. It equates to around 354 calls a month for a fall from a care home. So we're doing some work. We're doing some work with our care homes, increasing training and adopting the iStumble app, which so far, and it's limited sort of 6 months data, is starting to see some real real reduction. 14 homes didn't call Yaz at all in June, which is a significant decrease. We're still ensuring the quality of response to our residents in care homes, but we are reducing the trend of people going to hospital as a result of a fall. So it's promising work that we're looking to continue. Thank you.
Be helpful. That's a really interesting work. Leslie.
Thanks, Anthony. I'm really interested in a lot of this stuff. I think the stuff on employability is bang right. I mean, we know that we put barriers in the way of people. I was having conversations with people in Rotherham with Shahida, people from the Roma community saying how difficult it is to actually access these kinds of jobs because there's too many hurdles to jump. So I think, really good to see some of that stuff coming through, and I'm sure lots of learning there. I know we've had similar initiatives in Rotherham and Barnsley and other places, but I just think we need to keep learning from what we're doing. And from another life, just again really interested in the thing around falls in care homes. What we know, don't we, is that if we take older people or people with other vulnerabilities through that process of taking them in an ambulance and admitting them to hospital, it's not just the fact that we're doing that inappropriately, inappropriately, and it's costing us a lot of money, but actually it's bad for them. It's really, really bad for them. And the trauma of actually going through that process, you know, can set people really back. So I think on both scores, that's just a really good piece of work, and I'd be interested perhaps to have a chat with you about a bit more of the depth of the detail. So I'm really interested in that. So thank you.
Chris Rotherham.
Yes, thank you, Chair. So this feeds on quite nicely. So Chris Edwards, I'm the place director for Rotherham. Just feeding on that, the first thing in our report is work with care homes in Rotherham as well, so it fits in with the theme. So it's up for a national award. It's the Care Home Hydration Project. It's working with 45 care homes in Rotherham and then the hospital and community dietetic department. And it's about prevention and trying to train up we've got 1,100 staff trained in care homes. And what it's resulted in is we've seen immediately that reductions in calls to ambulances, admissions to hospital. It's entirely preventable with the right training and education. So it's just such an obvious thing to do from a patient perspective and from an efficiency perspective. So hopefully we're trying to roll that out across all 4 of our places, because obviously we have a South Yorkshire medicines management team. So that'll work nicely. So David, your team will be rolling that out with partners. Just picking up on community engagement, I couldn't resist putting these pictures. David, this one's especially for you. So David's a governor at Ardash who's with us today. There's a picture of an Ardash engagement event, which is, I put it in because it's a really innovative way of engaging the patients, governors, members of the organisation. There was a very long queue, I think, at the stocks to throw things at the chief executive, Toby, there. But to be fair to Toby, yeah, no. All the Rotherham partners sent people to support the event. It was a partnership event, but I just want to praise Ardash for just thinking differently and trying to engage people in different ways. And I think the more we try to do that, then the better we'll do. So just praise for Ardash. Another praise for Ardash, David. So you did pick the right meeting to come from. So Ardash are up for 2 awards, working on so Ardash are the Rotherham mental health provider. It's the acronyms for Rotherham, Doncaster, South Humber NHS Foundation Trust, and for Children's Neurodevelopment Transformation, up for awarding the Nursing Times Awards as well. So sticking on the mental health theme, the Rotherham Safe Space has been improved, reopened, relocated, and this is really a safe space which is available when all the services are shut. It's specifically targeted at adults, but it's about a safe space and a safe environment. It can be digitally accessed as well as physically accessed, and hopefully should give us a real safe space for people who are under pressure or feeling that they're in need of support that isn't there at this time of the day. And then the last thing I've put is, there's 2 more things. The Ofsted visit. So this is a real thing that's unique to Rotherham. Rotherham's had a very difficult past in terms of children's services, and particularly with the children's child sex exploitation report from it was Alexis J, and then the follow-up Louise Casey report about partnership working in Rotherham. And I just wanted to pick out some of the key feedback that was in the Ofsted letter that came back, because for Rotherham, the journey we've been on, it does feel as if we've got to where we wanted to get to. So it talks about the unstinting leadership and for the most vulnerable children. It talks about the commitment to child protection. It talks about the management of the Section 47 inquiries that relate to risks of abuse and harm. And it also talks about the child's voice and the multi-agency safeguarding arrangements, which obviously the ICB is an integral part of, and how we're using the family networks to increase support for families and children. This is huge for Rotherham, so I just wanted to make sure we noted that today, and it's a big praise to all the partners. And when I say that, it's the ICB as well as Ardash CAMS, as well as the people working at Rotherham Council and the Rotherham Foundation Trust. And lastly, the Place Board has had a major focus last month, so I just thought I'd bring this up. Fostering is something we're really keen to promote. Obviously, there's many links to health services, but the Place Board is trying to use our role as an anchor organisation. We employ over 20,000 people between us in the Rotherham Partnership, so we're trying to use that anchor organisation to promote and increase foster carers in the borough as well. So that's Rotherham, Chair. Thank you.
Chris, that's great. Any questions for Chris? Just absolutely. My wife is a fostering adoption social worker, so she will be impressed to know what's that. Ian, or Sheffield.
Thanks, Chair. Thank you, colleagues. So we've covered a little bit of the Sheffield update in the updates. But apologies for the duplication, Chair. And there is a typo on the PCN sites, which I'll come back to. Firstly, I just wanted to. I'll pick out a couple of things. I won't go through it word by word. I think there's been a really key discussion in the Sheffield Place in the last month under our HCP. And it's a fundamental one linked to our plans for urgent emergency care across the city, the end-to-end pathway dialogue that we've been engaged in now for going on 18 months. And what we said within our urgent emergency care group when it was established 18 months ago, that we'd look at three key things. The first was discharge. We set our strategy and we are now just over 12 months into that space and holding our nerve in a range of areas in that space. The second was in-hospital flow. There's a lot of work programs taking place, predominantly with our providers in that space to support urgent care pathways. And the final element was around same-day urgent care program. So how do we manage demand in our system across primary care and into secondary care and coordinate care? So in our latest discussion at HCP in August, we considered the kind of proposal and the program of work that we'll take forward in that space. Now that is a key milestone for us in Sheffield. We were positively supported by all partners in taking that programme forward. We will now take forward within that some key elements of proposal of change. The first one being our approach to clinical assessment services and having an updated clinical assessment service across the city. So we welcome that and we'll move forward. That will then be the catalyst for a range of dialogue and strategic dialogue and change and transformation around those front ends of the urgent care pathway. So I just wanted to highlight that. It looks top left, it doesn't look much, but it is quite a step change for us in the city. Secondly, Anthony, you commented around the PCN pilot sites. Sheffield has been successful in 3 out of 4 of those, and we welcome that in the city, probably covering over 100,000 patients in population. We think that's really good in the context of the locations of those PCNs, because there's a cross cut there in terms of deprivation and geography. As important within that, though, really keen to share all the learning out of that across South Yorkshire, and we're obviously really well linked into that. So really positive from our perspective. I don't need to say anything more on the northeast of the. I think we've heard enough about that. And I can't do it any further. Just within the second and third page of our update, there are a number of areas of good practice awards that have coming out of our providers across the children's, STH and Sheffield Health and Social Care, which we all welcome. I'm not going to go through those in detail. One of the things I would pick out of there, though, is the asthma friendly work that we've been doing with our schools. We got our first accreditation that came through the Children's Alliance. I just want to flag that to colleagues if you've not seen it, because it's right in the bottom left hand corner. That's coming out of the ICB. It's again what the first, but we hope it's first of many. So I just want to highlight those areas. Happy to take any comments or questions. Thanks, Chair.
Ian, that's great. Any questions? Sorry. Thank you. Right, we move on to items for consideration, discussion, health inequality and prevention diabetes. David, can I hand over to you?
Thanks very much, Piers. I've just got a couple of slides to help us talk through the paper, but while the team are bringing that up, firstly to thank the team who bring this together, because you can see that authors have quite a strong diabetic network in South Yorkshire, and that cuts across our providers, the ICB and a range of services. I'm sure everybody in the room will know somebody with diabetes. Certainly my mum has type 2 diabetes, my dad has pre-diabetes, and actually this paper takes me back a long way, because one of my first jobs in medicine was working for a diabetes consultant in Huddersfield. And I think while there have been many successes and we've gone a long way, I think what I hope to do is just highlight where we are at this stage. So if we can move on to the next slide, please. I'm going to start off with some of the challenges that face us. So unfortunately, diabetes is on the increase, and that's doubled in the last 20 years. So in my time as a doctor, and that still continues to rise. And actually, to give you some comparison, in South Yorkshire, our prevalence within our GP records show that we have a higher prevalence at 8% compared to the national average of 7.5%. Not only are we seeing more people with diabetes, we're seeing a change in the demographic. It would almost be unheard of when I qualified to have a type 2 diabetic in childhood, but actually that is being diagnosed now. So we used to say that type 1 diabetes, which is actually a problem of your pancreas functioning, would be seen in young people, and obesity being the predominant factor in type 2 diabetes would be more seen in later life. As we've highlighted already in this meeting, diabetes does not affect everybody equally. So if you come from a South Asian background or you're black, you're more likely to develop diabetes. Now, there's some genetic elements that underlie that, but also there's environmental. So the diet that we undertake affects us differently. Alongside that, we've got a LMNS and gestational diabetes. We are seeing an increase in that. But if you're a mother who is diagnosed with diabetes in pregnancy, then you have a tenfold increase in developing diabetes in later life. Alongside, in our deprived communities, we also see more people who diagnose and people with learning difficulties. As I've mentioned, obesity is certainly a driving factor to this. So what does it look like going forward? Well, approximately 20% of our population have diabetes or at risk of developing diabetes. Financially, what does that mean to the health service? Well, in the next 15 years, we could see that doubling of the cost to the NHS of from 239 million to 402 million. So they're quite stark. So doing nothing isn't an option in this scenario. Diabetes, as I learned when I was at medical school, does affect every organ in the body. So although we see it as a high blood sugar, actually the impact of that affects your vision, your kidneys, your circulation, and therefore you have lots of other conditions. So I'm going to move us on to the next slide, please. But I do want to pull out of the paper lots of good work that's been undertaken. As you've heard, we have got lots of campaigns about raising awareness in particular communities and targeting approach. We have a number of programs within the NHS that focus on diagnosing things earlier. If you have the pre-diabetes, like my father described, the diabetes prevention program is very, very successful in education and support of people that can offset people developing diabetes. And actually, we also utilize things like the diabetes type 2 to remission program, which has shown that ultra low calorie diets can actually reverse diabetes. So there are things that we can tackle the problem that's approaching us. We have developed a plan for, it's called T2 Day program, but it's really about those younger people who are developing diabetes that we hadn't seen previously. And there's a national program that actually our plans and actually implementing of that has been complemented by the national team. So that's good news for South Yorkshire as well. I recall back to many studies, the diabetic control and complications trial is if you can improve your blood sugar control, it does protect you from developing complications. And I'm glad to say that actually where we have positive control of diabetics, we are seeing benefits that have them. One group I particularly pull out is we have a very strong children and young people's diabetic service. Not only have they bucked the trend in regards to demographic groups who ordinarily have fared badly, but they actually have much higher levels of attainment in some of the targets than in comparison. Of course, we've talked about innovation and research, and one of the modern treatments that have come to light and people may be aware of and read about is this kind of hybrid closed loop. And it works on twofold. There's a continuous glucose monitoring device that usually sits on your skin, and there's a pump device that gives you insulin. And what this technology is combining the two, so it acts a bit more homogeneous in how our body would react. So that's a piece of work. And once again, looking at our children and young people's program, we have 58% of our children already utilising that, whereas the national average is 36. So we're really pushing the boundaries of identifying the right people and giving them the treatments. And of course, there are new medicines and therapeutics that come online every day. We're also focused on really supporting the transition between young people who develop diabetes and how they transition from the care they provide into adulthood, because I know that has been it's been a tricky time for adolescents and how they are going through lots of stresses in life and having a condition like this. So my final slide I'll go on to is really about talking about the next steps and then the ask of the board today. So clearly we want to build and accelerate the plans that are already in place. As I say, we've got a strong team that's doing some really good work. But actually my second point is really pulling out that it's not a medical model that's going to solve this. So actually we're in the mayoral combined authority today. We have a joint post with public health consultant and really looking at the causes, as Barbara Coyle would say to us, and working at how do we encourage people to be more active? How do we have an influence on the food systems that exist that drive some of the problems we have? So we have got a business case to expand the hybrid closed loop system. It is a bit tricky. The current funding for this year will probably give us an additional 100 people who will benefit from that. But we've got 7,000 type 1 diabetics, so there is still a long way to go. And I think there is a bit of a balance in the financial climate we're in, and we'll hear that from the next item on the agenda, is balancing that investing in prevention is certainly will reap its rewards given the challenge I've highlighted. So as Gavin has mentioned earlier, we are expecting the government's 10-year health plan. We were expecting a long-term condition strategy, but that never came to fruition. We've got a new government. I think there's an opportunity to look broader in this, and hopefully we'll feed into that. And NHS England has also announced that they intend to set up an obesity board. And once again, I welcome that, because I think it's complex and it's not, it would be difficult for us as individually to overcome that. And my final sort of ask is just the opportunity as a bit of a call to arms to accelerate some of our partnership working. How can we create the environments that make it easier for people to adopt healthy eating, remain active and maintaining a healthy weight? And I know, Christine, we've been working with, the team that falls under you and what's our offer to our own staff, because we have a lot of influence. So that's my final point, really. So I open it up for conversation. I hope people find these reports useful. I think it is a bit of a focus on, we're here as a health provider. So I certainly enjoy bringing these reports and sharing it with people. So as I say, I'll take any questions that might come. Thank you.
David, thank you. I think these reports are really important, not just on health inequality, but issues in health inequality, because they are slightly different. And diabetes is one we're all getting greatly concerned about. Leslie, you wanted to come.
Thanks, David, for this. I found it really informative, and I think it really demonstrates the multidimensional factors that are going on in contributing to the increase in diabetes. It is particularly worrying to see younger and younger people getting type 2 diabetes. And I think some of that we've really got to focus on those non-medical factors, because actually it is about people's diet. And we know that poverty is a factor in that. And, we had the inequalities conference, can't remember, last year before, and we talked about it then. And I just think it is really important to keep stressing that point. So it's great that we're seeing medical innovations and good practice that's helping to capture people once they've fallen into that group of people that are either pre-diabetic or diabetic. But it's also, how do we do that work to prevent people even getting to that point in the first place? And if we don't do that, then we're just stacking up issues for the future, aren't we? And it isn't just about money, is it? Because actually this is about people's quality of life, long-term health and well-being that we're talking about. So thank you. I've read it with great interest.
Thank you, Shafiq Hussain from Voluntary Action Rotherham. Just to say, the Cancer Alliance are working across all the 4 places, working with voluntary community sector organisations to target those communities, particularly where the prevalence of diabetes and the underreporting of diabetes, we've got the data on. So we're working with community organisations to inform and support residents on the things that they will engage with where diabetes is concerned, and specifically I know some partners are where individuals have missed diabetes appointments and screening appointments. Those individuals are being contacted to be able to book them in. So I think it's a whole system work which is paying some rewards.
Thank you, Shafiq. I've got Lucy, and then I've got Kevin online. Lucy.
Thank you. So there's a section in the paper that talks about community awareness, and it's describing some great work in terms of reaching out to different groups. The inequalities issue in this is really stark, isn't it? The figures make for really bleak reading. So this bit is really, really key. But I'm just wondering, in terms of that awareness, are we also ensuring that there's a kind of mechanism within there that we're not just sort of broadcasting out to people the information that we think they need to hear, but that we're actually listening to those communities and ensuring that we're understanding from their perspective what the issues are and what will enable them to tackle this, and feeding that back into the work that we're undertaking. Because I think we sort of heard from Gulnaz earlier about how they're working with their communities. That kind of circle of information is really important, that we don't just keep on doing the same messaging that we've been doing and expecting it to always be the right thing.
So Lucy, if I can respond to that, because one of the things I probably should have pulled out is that while there's an individual who have diabetes, it's far reaching of that. It affects families, it affects your ability, your education, and your employment as well. So I think the examples as were raised earlier this morning are the kind of, we need to disseminate that to really get in under the skin of it and go in there. And the team are doing a great bit of work, but actually it's not enough, because despite the work and the kind of the approach we're taking, we're not keeping up with the wave that's kind of preceding us. So I think that's why I call upon all of us here and all organisations to rally around. And Shafiq, I think it's quite helpful to hear that when you go into communities, we don't go in multiple times. So if you've got a risk of cancer, actually smoking, obesity is the next biggest risk factor for that. So actually they're the similar risks that affect a number of other diseases. So if we take a bit more of a holistic approach, then actually, as we've talked about, tackling poverty, giving people access to good food, that these will assist us in all of the medical conditions, not just diabetes, although we've highlighted a specific condition today. So not sure if I've entirely answered your question, but I think it's work in progress, and we continue to expand on what we've got in place.
I've got Kevin online, then I've got Shahida and Mark. Kevin.
Thanks, Chair.
Nice to see you, by the way.
Nice to see you all, and morning all. To some extent, it builds upon the previous points, because obviously food systems are a vital part of this whole issue, particularly the availability of affordable and healthy food. And to a large extent, despite our strong partnerships locally, particularly with the mayoral authority, in reality, what more can we do to lobby and push for a bigger solution to what is quite a fundamental part of this problem?
So Kevin, it's interesting that actually our input into the Darzi review was very much on the basis of population health, wider determinants of health. So that was the approach we took. We didn't take a medical model. We didn't ask for kind of, bigger hospitals and wider hospitals. So I think we've been consistent through our ICP strategy, our joint forward plan, that actually the things that are going to be the solutions are the things that are kind of out with the normal sort of a medical model that we undertake. So I think we continue to do that. I think it's good, as I said, that the government or the NHS have recognised having an obesity board, because not one of us is going to fix this, but I think there are things under our control. So when I talk to the directors of public health, there's about licensing for food outlets. What type of businesses do we want in the communities to support and help people to make good choices? Because let's face it, we're all tempted by the things that are not always in our best interest and affecting our health. So I think there's some things in our control. As you say, I think the next stage is lobbying broader